Well, thank you everyone for coming here today and giving me the opportunity to talk about our transition from paper falls assessments to really a geriatric and frailty assessment. I would just highlight our two. This is a representative of our DHB, represents a mother, a parent, a father, and the wraparound family supporting them. You'll find it's common on all of our themes, and within our organisation we proactively encourage the participation of whānau and family in all our care and planning. Our journey away from paper assessments occurred in 2013. I won't go into the details as to drivers, we've covered those well. But in addition to the national drivers, we had local drivers, which included actually getting the data we wanted from falls assessments was incredibly time consuming, and it made it very difficult for us to have any data-driven quality initiatives. Around this period, PDSA quality improvement cycles were becoming very much the vogue, and actually getting the data we needed to do that effectively was almost impossible. We also acknowledged as an organisation that falls were preventable, and they were actually inevitable. And that we were actually able to effectively assess patients and ensure we have individualised care plans. We did have enablers. We had electronic systems in place which worked. We had good levels of technology available to our staff. And we also had real drive as an organisation to actually match what's going on nationally. Subsequently to 2013, there's been many more drivers. Rather than starting us on our journey, these actually encouraged us to know that we were actually on the right journey. We were going in the right direction. If anything, they just provided traction for the work we were already doing. So how did we actually achieve changes? Well, the first thing we did is we took time to pause. We took time to look at things differently, look at what was around us. What did we do? We reflected on our key drivers for change. We went back to the National Falls Charts review, which Sandy had completed, to look at the 50 whatever different falls assessments. We went back to those original core assessments, the Morses, the Stratify and Hendricks. They may have had scores attached to them, but the questions they were asking were actually really valuable in helping to identify people at risk. We also went back to literature, looking at the best practice around, see if there's anything new coming up. And one thing we did is we aligned all of our assessments and falls and information, and we began to identify the consistent themes across all of the falls charts. Obviously they all had history of falls, some had medication, some talked about postural hypertension, mental state and cognitive function, need for ambulatory enablers, and continence all appeared on some, but not really on all of the charts. These consistent themes became headings within our falls assessment. And in addition, we recognised that falls reduction goes beyond patients and their families, but includes staff and the environment around us. We developed a new vision for our approach to falls. We knew we wanted every patient to be screened for falls or have a full falls assessment. We wanted there to be universal falls precautions for every patient in the hospital. This would make it safer not just for the patient, not just for their family who are around the bedside, but also for the staff in the hospital. I didn't mention it at the beginning, but I've got about 14 years frontline experience as an ED nurse and medical ward nurse. When we looked at those, it was amazing just how obvious they are and how easy they are to implement. As I said, we had 2 assessments I completed. The first step was creating a screening assessment. This was envisaged to be for people who we didn't think were very likely to fall, and we didn't want nurses to complete extended assessments. We used the questions, as you can see, and these were heavily influenced by the process markers developed from the Reducing Harm to Falls programme from the Health and Quality Safety Commission. The screen tool prompted nurses to complete the full falls assessment if the patient was identified as being at risk. The expectation was that nurses would use clinical judgment as a coverall, really, a safety net. This was reaffirming the importance of nurses using their intuition and experience to identify risks. Assessments by their very nature tend to be retrospective, looking at what has happened in the past, whereas nurses' experience and intuition enabled us to look beyond that and identify patients who were potentially at risk of becoming at risk of falls. We introduced it into an electronic assessment programme. We used TrendCare because our wards were already using that, and it was part of their business as usual, everyday work. For those we identified had been risk at falls, we had a much more comprehensive, full, detailed falls assessment. The themes identified previously when we did our review of falls charts and the literature became the headings on our themes. As you can see, it's predictable stuff: history of falls, mobility, vision, language and hearing. Within this assessment, if somebody was identified as being at risk, there'd be additional questions like, are those aids functional and appropriate? Are those glasses clean? Do they still work? When was your last vision test? With the benefit of hindsight, it was clear that actually these key themes were covering off more than just falls. But we were focusing on falls at this time, and we recognised that that had to be our priority. When the national clinical lead for falls is your Don, you really keep on target. That said, we also adopted the universal precautions: safe footwear, bed at the right height, orientating patients to where the toilet actually was to hopefully avoid looking for them, uncluttered space, warnings of wet floors. The concept of universal precautions to reduce falls isn't new. It's what we thought we did all the time anyway. However, when I looked at these and reflected on my own career as a nurse, other than safe footwear, because I'm rather partial to sensible footwear, I think each and every one of the remaining risks has either caused me to trip or nearly fall. Be like leaning on a bed which hadn't been secured, or trying to catch a patient who's sliding off the edge of the bed as the bed moves backwards. It was interesting times. However, we introduced our screening and full falls assessment in about Q1 of 2013. That's around sort of June, July time. The impact of the implementation was really quite quick. Within a quarter, that's 3 months, we had near 100% screening of either the screening tool or the full assessment. Universal precautions were at the forefront of all the staff's mind, and walking around the ward, it was quite obvious. Of course, this wasn't being done alone. There was productive wards and other programs going on at the same time, but they worked hand in hand, and I like to think we claimed part of success, just as the other programs contributed to ours. There were some negatives, of course. An awful lot of patients, much to my surprise, were actually having a screening tool followed by a full assessment. Now that took me back a little bit, but we rolled with it. We got feedback that actually, without the score, how would a nurse know what to do with somebody at risk of falls? And also some nurses just didn't like using electronic tools, which still happens from time to time, but I'm happy to say the resistance on that front is a lot less. Several staff also commented that they thought the idea was to reduce repetition of questions, and this wasn't happening. They were still needing to ask the same or similar questions. Initially I thought this was because they were doing both the screening tool and the full falls assessment, thus creating a two-step process. Other than identifying to me that practically every patient who came into our hospital was at falls, which in hindsight was relatively obvious, it made me think. And then I did what I hate doing when there's criticisms. I went down to the wards and started talking to the nurses who were complaining. Particularly when you built the tool, never a good move to do. I met and discussed the issues and concerns of these staff, and much to my surprise, the repetition they were talking about wasn't between the screening tool and the full tool. No, they didn't like the repetition between the full assessment and actually all the other nursing assessments they were completing. As a result of this, we picked up all that other nursing assessment. I was familiar with it, but I'd never really looked at it alongside our new falls. And then I had a bit of a realisation. When I say I, it was we. It really was. We had two systems. We now had a paper system and an electronic system. And actually, my desire to reduce the doubling up of questions had backfired a bit because it was still going on. The review of the documentation made it really apparent there were common themes with falls, and those same themes were common across other risk factors such as pressure injuries, dementia, cognitive function assessments, social and spiritual needs. There was a lot of doubling up going on. There was no doubt that extensive repetition was still occurring, and an opportunity for further improvement existed. This is where we started to realise that actually we created a new assessment for falls, but actually it could do more than just falls. We did mapping. The Office Max sold a lot of post-its. We looked at the care areas we commonly assess: the mobility, the continence, the nutrition assessments, the medication reviews, the vision, all the nursing assessments functions which we asked in our nursing assessments, and half a dozen other paper assessments, and we started mapping it out against risk factors which they influence. Rather predictably, a pattern emerged, which in hindsight I should have seen coming. Essentially what we discovered, albeit after some other clever people, was the influence of geriatric syndrome within our hospital setting. Now I should point out that ours is a secondary care hospital. We don't really have very many elective admissions at all, so inevitably quite a large proportion of our population of acute admissions generally reflecting the elder population. So if we were a big tertiary centre with a whole spectrum of services rather than just those standard ones, it may have been slightly less apparent. However, what you have behind me now is a definition of geriatric syndrome. I'm sure many of you will have noticed that actually the poor health outcomes are actually reflecting the exact same risk factors we identified in our care plan. That's when it sort of occurred to us that actually essentially we've been assessing for geriatric syndrome for really quite some time, but have been across multiple different forms and always with an element of repetition. Frailty was the other part of that equation. We did literature reviews again around geriatric syndrome, and frailty soon came up as something which is a contributing factor. Frailty is where a person can experience seriously adverse outcomes following even a relatively minor illness or change, such as an infection, a fall, or a change in medication, causing an acute deterioration of the patient's well-being. By creating a combined risk assessment which identified all the risk factors influencing geriatric syndrome and frailty, by reducing and mitigating these risks, we reduced the overall adverse health outcomes for patients. A model was found, again by somebody much cleverer than me, although it is rather simple looking once you've seen it. This model allowed us to understand that by reducing the risk factors to a patient, that's the green circle, we reduced the exacerbation of geriatric syndrome conditions, which in turn reduced the likelihood of a frailty event or a frailty triggering event from occurring. The overall effect being a minimisation of the likelihood of a poor patient outcome while under our care. Now the poor health outcomes up there I thought were really rather doom and gloomy. For me, a poor health outcome also includes things such as additional cost of diagnostics, extended length of stay, additionally complicated discharges, additional outpatients or specialty appointments, and essentially just costing a lot more money to look after that patient. We had a new vision now. That was we wanted a single assessment which would cover every patient. It would meet all the nurse-sensitive indicators, it would encourage critical thinking and not be too predictive, it would only ask questions once, and it would allow us to actually remove the screening tool for the fools. Practically everybody needed the full assessment anyway. The questions within the combined assessment would prompt nurses to look deeper into patient care, identify frailty contributors, and actions to reduce these and to reduce the risk of triggering a frailty event. Just here a little example of how we sort of went about this. Up there you've just got 2 questions from the assessment. That isn't the whole mobility component, but it's just 2 lines of it. Sitting underneath it within the programme though is a whole bunch of other information. If by hitting the no, you prompted the item to be registered as a risk, it would ask you straight away. It would tell you that your patient and their family need to be educated to risk of pressure injuries. It would also tell you that you need to discuss changes of mobility with the family. Is this new? Is it deteriorating? Is it the same? And this is going back to the patient and their family to get a good understanding of what's normal, what's changed, and what you can do to actually improve their outcome for that patient. You notice that this is about falls, but there's no mention of falls within those actions. The reason being, our nursing workforce was very familiar with falls by this point. It understood and could recognise just by clicking patient mobilises unaided without aids and no they can't, that they're at risk of falls. However, pressure injuries didn't have that same knowledge or same connection for many nurses, and as a result we discovered that we needed for some conditions to put more prompts in, more emphasis. Following on from this, other areas such as mental health, where their training has never really been around looking after that condition, looking after the physical condition, we've been approached to see if we can actually expand this more, move away from having less prompts and actually have more prompts so that they can actually understand better the physical needs of their patients, of their aging patient group. And we've started that work. It's not yet done completed, unfortunately. But in that assessment, we'll be spelling out in a lot more detail compared to our general ward staff, who we'd expect to have that better understanding and knowledge. I should say that our assessment is called the WHAKATAKETAKE. It was a name we were gifted by our local iwi. It stands for Information from Many Sources. And the reason for that is we actually don't want the nurse just to ask the patient. We want to ask the patient, the carers and the family, and anyone else who's actually got a connection with that patient who has information to contribute. We have some of the care factors it covers on the screen behind me. I could go on. We could add skin conditions, whether the patient had chemotherapy in the last 10 days, or many other care components which are included in the full WHAKATAKETAKE. Essentially, the assessment ensures that all typical risk factors are identified, allowing a comprehensive individualised care plan to be produced, that minimising the impact of geriatric conditions and adverse frailty events. The unexpected consequences of actually introducing the WHAKATAKETAKE was, firstly, me being here today. I never saw this coming. Secondly, we had actually developed a huge source of really rich data. We didn't quite realise how rich it would be until really much farther down the line. At the beginning of the presentation, I had a slide indicating that one of our drivers for change was that we wanted data for planning and quality initiatives, which was easily available. Now I can tell you what percentage of patients have fallen in the last year, what percentage have had an unsteady gait, or even what percentage of patients on a ward have urinary incontinence issues. And this is what we get. What I can also do now is mix and match that data. I could tell you how many patients on that ward had a fall in the last year and have an unsteady gait, or maybe falls, unsteady gait and incontinence, or falls over 65, and any other thing really in the assessment. We can mix and match. This is going to be really valuable for planning purposes and data analysis. I should point out the numbers behind me, they represent August of this year on 4 of our wards. It covers 100% of the patients. They all had the assessment completed. That's actually 768 patients, some of whom had multiple assessments covered. I should also say that creating that table and pulling the data took about 5 minutes, and in that time I had half a cup of coffee as well. So having that data really available is so important. Finally, we looked at what we could do next. Our next plan was really as to how we could actually use it for quality improvement purposes. Within the WHAKATAKETAKE, we have a component which asks the patient, do you want cultural support or Maori Health Service to come and see you as an inpatient? And the nurses would click yes or no or whatever. But then I went to look at the results and compared that to the patients the Maori Health Service had seen. And we saw very quickly that actually only about 15% of people who wanted to be seen were being seen. I worked with the Maori Health Service and created an assessment for them, which allowed us to cross-reference the patients who on the WHAKATAKETAKE who wanted to be seen with the patients who were being seen. We could pull up reports asking those two and comparing, and suddenly they discovered actually they could see each morning exactly which patients wanted to be seen, which patients didn't want to be seen, and who they had seen. Within maybe 2 months, we'd gone from 15% to 62% of patients who wanted to be seen being seen by the Maori Health Service. To be honest, I was disappointed. I was expecting that between 90 to 100%. I went back to the data, and sure enough, things had changed when you drilled down a bit. Not only had there been over 100% increase in people referred to the service, we found that the wards would be more responsive with the Maori Health team. And we also discovered that because the nurses no longer needed to do a written referral for that team, it really encouraged them to ask the question and put a meaningful yes in the box, because once they ticked yes, that was it, job done, move on. I was pleased. And we're still working on that to get that better. It turns out there are factors I hadn't accounted for. Surgical day unit, for example, often the patients are gone before the staff can get down, and so we need to do a little bit of work around that. But on the whole, really good. The next proof we've got really is our next steps. And for that, we've decided we've got an at-risk group within our community who really we've not done an awful lot with, and that would be the bariatric group. There are patients with very unique needs, needs which, to be honest with you, as a nurse, I didn't fully appreciate it until I started this work. We created a new question, one question for the assessment. That's not too much, I thought. Patient likely to need specialist equipment, BMI 35 plus. We thought, magic. We work with the system and we've built in an action so that if you are over 35 BMI, it creates an action prompt. That action prompt was actually a hyperlink to go to an outside organisation or a web page where you can actually order equipment. This would allow the nurses to order correct equipment for the patient while still at the bedside. In addition, we developed a form with the physio department which looks at the body shape of obese patients. I had no idea that your body shape influenced the care requirements and your at-risk factors for bariatric patients. However, now we've got a form which is linked in, and so we pull up the patient, pulls up the form, and it tells you the key care components and also the best models we can use and what the equipment is most suitably for that patient, which didn't come out very clearly at all. I apologise. This hasn't been implemented yet. It's still in a proof of concept, still in a rolling out sort of development style, but that's where we're heading. And it's taking a Falls assessment, took it beyond Falls into comprehensive universal assessment, which is hopefully going to minimise documentation and minimise referrals and offer plenty more opportunities. Thank you.